peak of 6. We put a P max 30, so the machine will not deliver more pressure than 30. Okay? May not be able to deliver the volume. If your volume is too high and needs to generate more pressure to get the whole volume, the machine won't allow you that and will alarm and will tell you that cannot deliver the volume because your PIP pressure is too low. So, this is the volume pressure loop. Okay? What you want to see is usually the angle of that loop should be about 45 degrees. If the angle becomes less than 45 degrees, means the compliance is worse. Okay? You also want to see the opening pressure here. You shouldn't see a very flat part here. Okay? So maybe the opening pressure for that lamp is a bit higher than 6 because you have a flat part here. So the machines need to generate more volume, more pressure than 6 to get any air into the lungs. So maybe increasing the peak to 7 or 8 will be able to start the curve right from here, not from here. See, this is the opening pressure here, and this is your peak. So your peak is lower than the opening pressure. Ideally, you want to have the opening pressure right at your peak. Okay? So the curve should start right away. Don't have any flat portion. This is not too bad. Sometimes you get a small portion, but it shouldn't be very flat. Okay, so let's make now the lungs worse. We're going to decrease the compliance. Okay? So let's see if we can do that. Let's see if we can block one of the lungs, make the compliance worse. And see what kind of changes we. Oh, sorry, before that, okay. Another number important to watch is the 1.2, which is a normal compliance. It's not bad. Okay. And the PIP pressure that, where are we showing the PIP pressure? We don't have these new machines that drive.
We have 500, this is 600.
Yeah.
We need to get it.
So what are you?
Yeah, like this.
Okay, so your PIP pressure is 10, which is very low. Okay, so don't tell these lungs are very normal. Okay? Normal compliance, very low PIPs. Very good compliance. The only thing that I would maybe consider is the people is better. So now we're going to make the other number that is important to watch is the C20 versus over total compliance. You understand what that is? Yeah. It's basically looking at, the machine is looking at the last 20% of the compliance curve and divide that by the total compliance. In a normal situation, you shouldn't have a difference. It should be the same. When the last 20% of that compliance curve is significantly less than the total compliance, means that you have over-distension. You get to a point that you're increasing the pressure without getting volume. Okay, so the last 20% of the compliance curve is significantly lower than the rest of the compliance. So your C20 versus C is maybe very low. So in that case, you may need to do something about it. Okay, let's make it worse and see if we can do that. There you are. So did you change your? Okay. Okay, good. So what kind of changes do you? So you made the compliance worse. So what kind of changes are you expecting to see in these parameters that we just reviewed?
The pressure is higher.
Okay, so the PIP pressure is higher. Why is it higher? Why is the PIP higher? Right, because you need more pressure to deliver the same volume. Okay, what else? The compliance number. It was 1.2 before?
Yes.
Now it's
0.62.
0.62. Yes. Okay. C20 over C compliance is close to 1, it's normal, so that's not a problem. Okay. And on the curve, I can't tell really if the curve is more flat.
Yeah, but the height that PIP is higher.
Yeah, the PIP is higher.
Yeah, now we make it flat.
Yeah.
Okay,
That's good. Okay. Look at the now. It's not 45 degrees anymore. It's maybe 20, 25. Okay. And you don't have this flat part here, and you don't get much increase.
Yeah.
So your compliance definitely has changed. Okay? So when your compliance change, your FAAP usually goes up, your PIP usually goes up. The volume is not going to change because you're on volume guarantee.
Yes.
If you were in pressure support, what would you see? Lower volume. Now with the same pressure, now you're delivering less volume. Okay. The number for the compliance will go down. Okay, and the C20 over C, if you don't have overdistension, shouldn't be the same. Okay, good. So you can make overdistension right with that.
Overdistension?
No, I don't think so. Unless you really stretch it and keep it open.
So back to normal compliance?
Yeah, go to back to normal compliance. See if you can stretch that. Okay, so the other compliance is better. So the PIPs are coming down.
Look at the beat.
PIPs are coming down. The angle has gone up again. Okay.
I think you said the kind of volume
Maybe I think that's not right. So can I make the volume higher?
Yeah.
It would be fine because this slide is maybe also 2 mm.
Okay.
So simplify the volume high.
That's better. Okay, so you have both rounds going now? Normal compliance?
Yeah.
Okay, so that's normal compliance. Don't move, don't move. Okay, so again, this is perfect.
Yeah, now also
Yeah, don't. Okay,
that's what?
let's go first to normal and then change.
Okay, that's one.
Normal.
Normal, but we will be high side of volume. And this is the type of volume of this one.
Let's go up on the peak. Let's say you go up on the peak to 8. Let's see if we can see the change. So how is the peak changing the peak? It's going to change your compliance.
Recruiting more
Yeah, you recruit more at your lives. The more at your lives you recruit, the compliance goes down. Sorry, it's up. Okay? So all of a sudden you're going to get more volume for any unit of pressure. So you're basically moving the curve. So if your curve is like this, you're going to move it like this. So you get more change in volume for smaller changes in pressure. If your curve is flat, you need significantly greater changes in pressure to get less volume. So what you need to do is you need to move the curve up.
Yes.
The best way to do that is by increasing your peak. Okay? And I have a graph here that with numbers that I can actually show you exactly mathematically how it works and what changes you get in numbers. So where are we now? Are you in 1 line, 2 lines?
2 lines.
2 lines, okay. So
Was one?
that's not bad. Okay, let's go to 1 now. Let's see what happens.
Oh, yes.
So the PFE, see the PFE now? The 20 now. Okay. Now,
And the C20 or C6 now is 1.2. Now it's down.
Okay.
Compliance is down.
and your compliance now is half.
And
Yeah,
the curve
compared to 1.
is more flat.
The curve is more flat now. Okay. So, and your
Can you make it
PFEs
worse?
are double. Can you make it worse? Well, look at that. Okay, what is this? So
Now,
now,
she should come up now because
you understand why the inspiratory limb it has a lower compliance than the expiratory limb? Because you compare this, they're not superimposed. This is inspiration and that's expiration. So the expiration is always higher. So the expiration gets better compliance with expiration. Why is that?
Already open.
That's negative pressure.
No, but if you, on inspiration, you opening the lungs. On expiration, you are de-recruiting the lungs. So you should go back, normally you should go back the same way. Should be overlapping. Why they are not? Why they are not overlapping? And when you see the two lines almost overlapping.
Yeah.
No, the functional zero capacity is this part here. Okay? That's where you are.
That's it.
But why are the two lines not overlapping? Why is not like this? No, no, no. It doesn't matter if it's passive active, it's compliant. So it's volume or pressure, the relation between the two. When do you see the two lines getting closer and closer and closer? With Hallen membrane disease, with surfactant deficiency. Okay? So why the two lines are normally separated? Because surfactant is so efficient that when on expiration, the surfactant is so efficient that actually makes the compliance curve of each alveoli better than on inspiration. Surfactant only works on expiration. You only need surfactant for expiration, okay, to prevent alveolar collapse. But it's so efficient that actually lowers the compliance, improves the compliance significantly more than when you don't have surfactant. So when you don't have surfactant, the two lines are together. So you need to have some separation. Okay? When you see a significant separation between the two, like an abnormal separation, when you have obstruction. Okay? When you have obstruction, sometimes you can have inspiratory obstruction or expiratory obstruction or both. Let's say you have a tracheobronchomalacia or you have a vascular ring. So one limb would be significantly bigger than the other when you have an obstruction. So that all that is shown in the volume pressure curve. So in the volume pressure curve, you look at the angle for compliance, you look at the opening pressure, that will tell you exactly what the ideal peak. You will see if there is any leaking or overextension by looking at the shape and also at the C20 over C. You will also look at the separation between the two. If it's too narrow, most likely you have surfactant deficiency. If it's too wide, well, it depends if it's both are significantly bigger or just one. You can see if it's an inspiratory obstruction or an expiratory obstruction on both. Okay? All that information you can get from the volume pressure curve. Okay? And again, when you do the recruitment, you change the peak by one at a time. You wait 10, 15 minutes, and then you see changes. All those changes that we just discussed, you look for those changes and see what happens. If you don't see a change, well, you may need more than one. You may need 2 or 3. What about if the problem is not at the leg vessels, and then you think that you should increase the peak when that's not the solution? Maybe the solution is decreasing the peak. Let's say you are ventilating this baby on the top part of the curve. Okay? So your compliance is low, not because you don't have enough volume, because you have too much volume. And if you keep increasing the peak, you're going to make it worse. Right? So how can you tell? If you increase the peak, and the number, which number will get worse if it's not at the leg? The C20 over 2, yeah. What about the PAP? It's going to go up.
Yeah.
It's going to go up. It's going to be worse. Okay? And so, right. So the volume is going to change, but you're still in volume guarantee. But your PAP is going to go up when you increase the peak, and your C20 over C is going to get worse. Okay? So, and again, if you're on pressure support, you should look at the volume. You should do the opposite with the volume. As I said, most of us will just use volume guarantee, so we only look at the pressure.
So are you using more volume guarantee or pressure?
Volume guarantee.
Volume guarantee?
Volume.
Yeah. Yeah. Very good. Okay.
So you want me to show you this? See,
Yeah.
I'll give you an example now with numbers, how changing the compliance curve will give you more or less volume and change the compliance. So, here we have an example. Okay? So this is the study of pressure. Okay? So here is the sum of the two. You don't have two because it's not dynamic, it's static. So this is kind of the average of the two, the expiratory and expiratory. So this is a normal compliance curve. Okay? So this baby is being ventilated with pressure. Okay? This is pressure ventilation. So you have for 6 and a PIP of 19. So your delta P is 13. Okay? The volume that you get with that pressure is 12.3. So how do you calculate the compliance? Yeah, we divide this number divided the pressure. Okay? So 12.3 divided by 13 it will give you 0.95, which is very normal. Okay? Now all of a sudden, for whatever reason, this baby will lose volume. Let's say the baby was intubated and the nurse by mistake disconnected the tube and the baby lost volume and the baby collapsed, got atelectasis. Okay? So now all of a sudden the compliance curve went up. Okay? It's flat. Okay? So and you haven't changed anything yet. So the ventilatory parameters are the same. But now with the same 19/6, your delta P is still 13. But now the volume that you're getting is only 7.8. Okay? Same ventilators, nothing has changed. The only thing that changed was the compliance curve. Now your compliance now is 7.8 divided by 13, which is only 0.6. And that confirms that compliance is worse. Okay? So how do you recruit? How do you go back? Because definitely you can maintain the same settings, but the compliance curve is the same.
Increase the peak.
Okay? So let's say you increase the peak to 8, okay? And you want to maintain the same volume, because we don't think it's volume problem, we think it's just atelectasis, okay? So you maintain the same delta P of 13, so you go 8. Okay? The compliance curve now is going to go up. So you're increasing the curve now, okay? So by doing that, you only increase the P, you maintain the same PIP as before. Now your delta P is less. It was 13 before, now it's 11. But now because the curve has moved up, now you're getting 8.2 mLs of volume for less pressure change. So now when you divide 8.2 minus 11, you get a compliance that went up by almost 30–40%, from 0.6 to 0.8. Okay? And the only thing you did is by changing the P. So you basically move the compliance curve up. So you didn't have to change the PIP, actually you are getting less delta P now. But now your numbers are better, your compliance is better, and if this is true, your FA2 should start coming down. You have less intercompliance shock. Okay? You have less atelectasis. Okay? So, I'll give you an example of the opposite now, when you have overextension. Okay, let's say this is the compliance curve, okay? So right now you are using a PIP of 7 and a PIP of 20, okay? So you're ventilating the baby, the lungs, not in this part of the curve, that's where you want to be, but you're kind of pointing towards the upper part of the curve. So you have a delta P of 13, 20 on 7, so what's your volume? Is 8.7. So you divide 8.7 divided by 13, your compliance is 0.67. Okay? So you're ventilating these lungs in the compliance part of the curve that is only 0.67, okay? Which is quite low. So what's the problem when you have overdistension of the lungs? What could be the problem? Yeah. Besides polytrauma, but in terms of blood gases, ventilation, oxygenation, what's going to be the main issue?
Compressing the heart. Compressing the heart.
Right, but let's say it's not, yeah, you can have decreased venous return, but that's when it's excessive. Let's say you have a minor overdistension. Okay? You're not compressing the vasculature, there is enough pulmonary blood flow, you haven't changed that. So what happened when you over distend the lungs?
gas exchange. Gas exchange.
How is the gas exchange impaired?
الانترفيس
Ventilation,
الانترفيس
perfusion is not.
One at a time, okay? You.
The babies are like compressed body air.
As I say, that's when it's excessive. Let's say you're assuming that you're overextending the alveolus and you're not compromising the pulmonary blood flow. Pulmonary blood flow remains normal. So what's the problem with distending the alveolus a little bit more? What's the big deal? Besides causing volume trauma. How is that going to be reflected in the blood gases, on
CO2
ventilation,
retention.
or oxygenation?
CO2 retention. CO2 retention.
Why? Why are you going to get more CO2 retention?
Increase the distance.
Increase the space. Very good. So you're using the same type of volume now, but now because you're overextending the alveoli, some of that volume now is going to be wasted in more dead space. So your alveolar ventilation is going to go down. Remember, alveolar ventilation is VT minus dead space times frequency. If your dead space increases, then you have less VT to go to alveoli. Okay? So with now you're over distending the alveoli, you're going to get less alveolar ventilation. Your CO2 is going to go up. Your oxygenation may not change. Your baby may be in room air. As long as you don't compromise the perfusion, your ventilation is at least 1-to-1 or close to 1-to-1. So increasing dead space should not, at the beginning, if it's not severe, should not compromise your oxygenation. Should mainly compromise your minute ventilation, which is CO2. Okay? So when you make the changes, you may see all of a sudden CO2 coming down without necessarily seeing a change in oxygenation. Okay, let's see. So what do we do here? If you are ventilating the baby on that part of the curve, let's say you bring the P down to 6 and the 19. So you maintain the same delta P, but now you're going to move both lower. Okay? So now all of a sudden, the volume that you get is 12.3 because you're using a much better compliance part of the curve. Now your compliance will move from 0.6 to 0.9 just by decreasing the P and the PEEP and the PIP by 1. Okay? So you less distance to the lungs. Okay? You see how that works? Same here. So you have 24/7 and delta P of 17. Your total volume with that delta P is 8.9 and your compliance on 0.52. So what you do is now you think the PEEP is fine, but your PIP now went from 24 to 20 without changing the PEEP. So your delta P now is only 13. Okay? Now your volume is still 8.7, which is the same as before, but now the compliance is 0.67 because your delta P significantly decreased. So before you needed almost the same volume with much higher delta P. Now with significantly less delta P, you're almost achieving the same volume. Okay? Follow? So that's why it's important to know exactly where you are, in which part of the curve. And that the machine will give you, be able to tell you that. Look at the compliance numbers, will give you a ton of the PIPs that you're getting, the C20/C, the shape, the angle of that compliance curve. And okay? So don't forget to use your pulmonary graphics and the numbers that all this fancy machine will give you. Okay? Don't use your imagination. You think it's better or worse. Because you have very objective way to measure what's going on in the lungs. I always tell the residents or the fellows the importance of people don't think that the pulmonary graphics are important. They are not essential. You can we have ventilated babies for 30, 40 years without the graphics. But it's like when you go in a hike, and you go in a hike without any maps or any GPS. Eventually, you're going to get to the other side. It's going to take you 3 days.
It's in hikes, like solo with the diet.
Okay, so it's going to take you 3 days, you're going to get lost in the middle, but eventually you're going to get to the other side. But if you got a GPS and a map, you can go straight to the exit in much better, faster, and more enjoyable time. This is the same thing. You can ventilate babies without and with pulmonary graphics. Using pulmonary graphics, it's going to be more enjoyable, and you're going to be using it as much safer way.
You are using the graphics instead of EEG.
No, we do both. We do both. Everything has different advantages. We do X-ray, we do live ultrasound, we do blood gases, we do pulmonary graphics. Everything will give you a different type of information.
Yeah, X-ray use reduced maybe by more than 50%. Especially for
May I ask a question? It's just that the chronic disease rate, because real life is totally different when you try to decrease the oxygen, make changes. Those babies usually agitate, especially on the CPAP, and they are continuously saturation just really up and down, up and down. So how do you, and you want to avoid sedation, you want to try to minimize whatever. So how do you do that? I mean, they always give it. And if you leave them alone, they will be hard. You just do anything, you try to adjust, they decide. Sometimes it's really hard to play with that, looking at your words, because they are very, very dynamic and changing.
right, we are not really laying that much. The infant's really stable. So if it's stable, we don't have to do anything. And just to need to probably wean or consider like discontinuation of the might be that doesn't need a CVAD to CVAD or rotating. It might be that. So we do that on daily basis when we run around every day. And we have the team, the respiratory therapists, the nurses and everyone. Our aim, like to wean or to discontinue, particularly for not for invasive ventilation. So the main question that we ask for any ventilated infant every day, how we can get this infant out of the ventilator as soon as possible. So we have short-term plan that we need to exhibit him today, and we have to make a plan for that, or we cannot exhibit today for some reason, then we have to do that tomorrow or after tomorrow. Or we need a plan to this infant, like within a few days, longer term plan to give steroids, for example, or whatever. So we should have a clear plan, not just run around and he's ventilated, leave him alone. That's not acceptable. If he is on non-invasive ventilation, we encourage more non-invasive if it is indicated. So another question that we have, should we wean CPAP or discontinue CPAP or escalate if needed? And to do that, we have the parameters. We have to respect the parameters. The oxygen histograms, so that's routinely every day during the round that's part of the represent that. We know exactly for last 24 hours what the oxygen histograms once in a while. Because the bedside nurse will tell me the saturation now is 95. So what does it mean anything? I need for last 24 hours what happened. How many apnea bradycardia? And how many of them require any intervention? How many of them the bedside nurse stimulated the baby, required intervention? Now how many events require banding, like fire? So I need to escalate. I need to maybe do lung ultrasound. And if the lung is derecruited, then I need to escalate and give more support. So each step, higher or down or whatever, should be based on a lot of information that we get. Daily, we have oxygen histograms. We have the number of events of desaturation to last 24 hours reported by the bedside nurse. Now with the new monitors, the Meditronic one that we are getting, the machine itself will record. And the new machine with the CPAP, even with the infant of CPAP, there is an option that can adjust the pause in the machine. The machine can deliver if there is a pause more than 20-30 seconds. As good as non-invasive machine. So if the infant pause will not increase by 10 seconds, 15, 20 seconds, we usually adjust by 20 seconds. The machine will give the breathe, non-invasive breathe to the baby. So the nurse does not need to come and stimulate, or, the old-fashioned way of recover, like trying to stimulate the baby to recover from apnea bradycardia. So all of these information are important before we do any changes. And to get us the infant less agitated. If the infant is growing and now we are in CPAP, probably he doesn't need the pressure, and we need to get him less agitated and more feeding. We shift to high frequency nasal candy. So that's another step of weaning down if we are unable to discontinue CPAP. And once we reach close to 36 weeks, we get very, very eager to wean as much as we can, not to get this infant labeled as chronic lung disease, because that will increase our number of chronic lung disease. Like before that, we try to wean to check his potentials.
sometimes they end up. Now, we need to be sure that it's not something that we can do to correct it, or we are responsible for that. Sometimes it's very, but we need to be sure at first that you are providing good ventilation. Sometimes babies are unhappy because you're not providing what they need. Okay? Sometimes you're not giving enough volume. Sometimes the lungs are lethargic and the baby's hypoxic, hyperoxic, the baby will not like that. And also synchronization is very important. You need to ensure that you are synchronizing the babies the best you can. Sometimes we use the backup rate too high, and that will make the baby crazy when you have an active baby, because the machine only has 1 second to synchronize. And most of the time, the machine will kick in before the baby can take a spontaneous breath. If the baby has a pulse of 1.1 seconds, the machine will not wait. So that will make the baby over 24 hours very irritable, very unsettled. So you need to be sure that you adjust the synchronization to make the baby happier, recruit lung volume, use the right volume for the baby to be comfortable, adjust the flow. Sometimes you're not getting enough flow, and the baby has to have another breath on top of a breath. So all those little things can make the baby quite irritable. And if you don't look for those things, you're going to miss it and you think, oh, the baby needs more morphine, or more fentanyl, or more, so that's not the solution.
You just need the mom to come and synthesize.
Yeah, sometimes it's just agitation, I agree. But sometimes it's us, that we are not providing what the baby needs.
Okay. They're asking if we're able to use the graphs.
No, unfortunately, you can't. If you're on high frequency, you lose your tomography.
Yeah.
You get some numbers, but
Yeah, you get the numbers, but yeah.
I mean, I don't know if the new machine can give you some.
Because there is a flow sensor, as long as you have a flow sensor. If you don't have a flow sensor, probably you will not get that. But the flow sensor will take some chance.
The problem with this is that if you have a leak, you're never going to be 100% accurate. That's the problem, because our endotracheal tubes doesn't have a balloon, so you always have a leak. That's why sometimes the curves go all over the place because of the leak. So that's something that you have to deal with. So you have to wait until you have a stable, no leak situation, or a leak that is consistent with 10, 20%, and then that's where you compare. Because if the leak is jumping up and down, then your numbers are going to go up and down.
Since you mentioned that, I want to ask about a baby on a running basis. How do you keep, do you use a chin pad or maybe a dummy? How to prevent that?
The nurses know more than us.
That's actually there's talent.
Yeah, they're the nurses.
Yeah.
Because they're there all the time. So yeah, we try to keep the mouth closed, put a chin trap. But everywhere is different. I don't know if you have any other. I think it's just, I ask the nurses, what do you think is the best way to keep the mouth shut, and they will tell you.
So the nurses, sometimes with the parents, or the mother or dad at the side, they usually help. You can stay hours and watch the muscle when they can help. The ratio for CPAP is usually 1 nurse to 2 CPAP. So sometimes you use video, and they are still at rooms. They are not in the same room. She might move to the other room, but the monitor's connected by electronic Proessor. If there's anything happening with the monitor, she will connect that. She will notice that there is something happening with the other room. So move, like this equation, whatever. But that will detect if something's wrong and coming out, and maybe CPAP pressure loss. So that's another way. But that's might not be applicable on all of the bases, but we encourage parents to be on the side to help. Nurse is a key success. So CPAP is great to be So if you're able to maintain the pressure by all means that you can, then you will get the success.
Yeah, sometimes, believe it or not, sometimes I find that the histogram will change based on who is looking at the baby. Yeah, so there's some nurses that are very obsessive. I will keep the size where you tell them to keep them, and we keep the thing in nose. Others, they are busier or they are not so obsessive, and the histogram will be all over the place.
Okay, thank you. Maybe we'll move next to, because we are tight now in time. You will come to pick up, pick you up unless if you would like to come with us. cardiovascular, the challenge. Now we discuss the challenge on the respiratory support. Now we discuss the challenge with cardiovascular.
Tropic drugs were.
Yes. So we have two case scenarios with different initiatives support. So how to select the right one? Yeah? Case scenario number 6. I have two cases, so maybe I select. This is a challenging case with cardiovascular support before OR. So let us see how we did with this case. At the end of this case, you will be able to demonstrate the detailed cardiovascular assessment of the hernia, demonstrate how to select the support, and demonstrate the related echo markers. So I have the echo a little bit detailed, so this case is more detailed. So interesting case. So term infant born by C-section, emergency section, relocated bradycardia. So there is an element of prenatal depression in this case, for sure, because of congenital anomalies did not qualify for cooling. But was actually there's a prenatal depression which is contributing, is making the case even more difficult to manage the cardiovascular part. So this is a lung ultrasound image confirming that we have bowels. You can see the bowel loops in the chest surrounded by some fluids. So we need the sound again.
هو انا قلت له انت بس ثاني كان عليا كمان يعملوا حاجه الواد خليفه كان لابس
Hi, my name is Dr. Duncan. I'm a nurse in the Neonatal Intensive Care Unit, and I work at St. Mark's Hospital in Winnipeg, Canada.
Hi, my name is Mansoor Farooqi. I'm a radiologist at ASNC-CME and San Luis Hospital in NICU, Winnipeg, Canada.
Hi everyone. This is a term infant, born with low OPR scores and lactic acidosis required mechanical ventilation and inhaled nitric oxide due to clinical pulmonary hypertension. The clinical history, blood gases and neurological examination were consistent with perinatal depression, but did not qualify for hypothermia protocol.
So since we started nitric, we've been able to wean our FO2 to 55% when we were initially 100% before starting. She's now about 6 hours of age. However, I am a bit concerned about the blood pressure, consistently reading around 54/50 with a mean of 52, but only a pulse pressure of 4.
I see narrow pulse pressure. What about the blood gases and lactate?
The blood gases are concerning. The pH now is at 7.23 with a CO2 of 51, but the bicarbonate is only 14, and the lactate is all the way up to 12.
Also adding to that, the tissue oxygenation has been consistently reading 50 for both, which is below the normal of 60 to 80.
We have low tissue oxygenation because decreased blood flow through the organs. We need to involve hemodynamics community.
Okay.
Hi, welcome back everyone. This echocardiography study was done for a term infant born by emergency C-section because of the fetal bradycardia. This echo study was requested around 6 hours of age. This infant was born with history of perinatal depression, but did not qualify for cooling at the time. So the blood pressure was initially normal, but at the time of echocardiography, the pulse pressure was very narrow. So systolic was 54 and diastolic was 50. Pulse pressure was only 4 millimeter mercury. The lactic acid started to increase, and shortly after birth and before echocardiography, we required high oxygen fraction of 200% and started on nitric oxide, and the FI came down to around 50 to 60%. So at the time of echocardiography, it was already on the nitric oxide. So in this image, we have apical for a chamber view. And again, look at the contractility, filling, in performance of both left ventricle and right ventricle by eye pulling, and then we'll move on other measurements. At the end, we should have a conclusion before formulating the medical recommendation for this infant. So we have very narrow pulse pressure before even we started echocardiography. We have now impression of vasoconstricted physiology. We have normal or high diastolic pressure and very narrow pulse pressure. And that could be explained by the perinatal depression. And also we have a clinical picture of pulmonary hypertension. So we have the left ventricle, which is not really contracting well. So I cannot see the free wall here is really squeezing or moving towards the cavity, and the septum is moving more paradoxic. The same for the free wall of the right ventricle. Right ventricle does not really contract very well, although the filling is okay, but the performance overall is poor. With color, I can recognize just very trivial mitral regurg. There is no significant tricuspid regurg. And then when we applied in the mood with the tissue Doppler, and we measure Hep C, tricuspid annular peak systolic excursion, it was really low. So it was 0.4 centimeter. Anything below 0.5 centimeter is a marker of poor RD performance. Then we measured the VTI from the apical 5-chamber view, LVOT. So even without the measurement, it looks very low VTI, signifying low cardiac output. So go to aortic, LVOT trace, measure the trace. And it is just 4 centimeter. So it is very low. But we have to calculate the cardiac output. We have to measure the diameter of the aortic valve and measure the cardiac output. And then if we go more anterior, you will get the RDOT, and also you can evaluate the RDOT trace, or also you can do it from the parasternal long axis view. So this is a parasternal long axis view, and again you can see the right ventricle anterior wall does not really contract well, and the overall performance of the heart is not really good. And this is actually the RDOT view from the parasternal axis. And here you have also the right ventricle outflow tract Doppler, and we can assess the trace, and we'll assess or measure another parameter, which is also very useful in the assessment of pulmonary hypertension. So go to pulmonic, RDOT trace, measure the trace. And then there is another measurement, which is the ratio between the acceleration time to ejection time of the right ventricular outflow tract Doppler. So the time from the beginning up to the peak time, we call it the acceleration time. And this time should be around 30 to 50% of the total ejection time. The shorter the acceleration time compared to the total ejection time, the more significant the pulmonary hypertension. So we can do that through the generic time and measure the time from the beginning up to the peak. So we have the time now is 28 milliseconds, and the time from the beginning to the end, so the total ejection time, which is 171. So if we calculate the ratio between both, 28 to 171, you will get around 0.16. If the ratio is at 0.3, it is a sign of pulmonary hypertension. And the less ratio between the acceleration time to ejection time means more pulmonary hypertension. So we are going the opposite direction. Low ratio with high pulmonary arterial pressure. Then look at the short axis view, and again you can recognize poor performance of contractility of the right ventricle, and it is more dilated compared to the left ventricle. And the second is flattened in diastole and goes from right to left in systole. And to recognize that easily, stop and not frame by frame. So you have flattening in the diastole, and if you remove the frame towards systole, you can see the septum now moves from right to left. So it's moving paradoxic, which means you have the right ventricular pressure at the end of systole higher than the left ventricular pressure. So it's suprasystemic, only after pressure.
Yeah, I think we have enough information from the input because I'm going too much in the details. So now I need to listen from you. So we have this infant, based on what we discussed yesterday. This infant born with congenital bradycardia, with the prenatal depression did not qualify for cooling because we're associated with the illness. And then, after start of nitric oxide, because of clinical depression and hypertension, the lactic acid started to increase up to 14 or so, and the near-field spectroscopy reading is really low. It means that there's significant compromised systemic blood flow. And we have now pulse pressure, and we have from the echo poor performance of both ventricles, mainly right side. So what's the make sense medication to be considered now? Maybe no. Very good. So yeah, you got the lesson from yesterday. So let us now see what happened with the next step.
How is he doing?
Baby's doing really well. It's now been 6 hours since we did the TNE echo. So as a result of that, we gave a bolus of 10 mL per kilo of normal saline. We also started milrinone at 0.33 mics per kilo per minute. We then had to increase that up to 0.5 mics per kilo per minute. Our blood pressure has responded. We're now 58/34 with a mean of 45.
We have normal blood pressure or pulse pressure is going to be well. What are the blood gases impacted? Well, nicely, the blood gases have improved with an HL of 7.30 with a C2 of 49, and that's with the country that we want to Our bicarb is going up now to 20, and lactate is actually improved now, it's 4. We're on 35% oxygen. I guess the question I want to ask you, should I really need the nitric oxide?
We will consider echo before we have those.
I've also noticed that the tissue oxygenation for both brain and body has improved. Both are now reading 70.
I am expecting our echo to be better because blood blood flow to the whole body and tissue is greater because the tissue oxygenation is better than before.
So we have done the echo, and the echo is showing already improvement of everything. That was just 6 hours after the and we did not require more than 0.5. So what? Exactly. Yeah. So why bolus normal saline is given? So you remember, you maybe recognize that the LB was little bit compressed from the myelinated heartbeat. Yeah. And when you give a vasopressor, if there is no any impression of volume depletion, you don't have to give any volume expanders. But when you give inotropes, it is better if you don't have an echo to blind the heart with 10 ml per kg from a saline. Why? Usually the inotrope will improve the systolic performance on expense of the systolic compliance a little bit. So you may get maybe a little bit hyperdynamic tachycardia, so the volume might be affected. So if you don't know exactly that the volume is good, it's better to blind the heart before you give inotrope. I mean the inotrope, bumetanide or merinon or epinephrine. If you are giving vasopressor, not epinephrine or vasopressin, you don't have to do that. Make sense? Usually, and if you give the dose, which is might be unnecessarily sometimes inotropes, the filling of the heart will be worse. And that's one main reason when you have very high dose of inotropes, the heart filling will be very bad. Make sense? We just blind the heart to get the inotropes more successful. And that you need to do just 10 ml per kg.
اعتقد ان احنا يعني اور سيتويشنز ان الاكل ما بيبقاش سريع قوي لازم اعتقد ان احنا كنا هندي ال 10 مللي يعني انا ماي امبريشن ان انا كنت هعمل كده.
Yeah, تمام. Yeah, that's very good. You will not harm by doing the just CME. If you give too much, that's harmful. You give 20, 30, 40. That's not really that might impact negatively, especially the So I have another very short case scenario with a different presentation.
You are doing echo before the before weaning the INO. يعني you are doing this is the protocol you are doing echo before weaning the INO.
Not necessarily.
Because I hear
because this case is really a challenge. Echoes defer, and also this infant required another agent, which is Minitoba. So we need also to check the improvement of the performance after Minitoba. That's why echoes indicate. If the infant's already like nitric oxide, oxygenation improved to air, and those going fine, you don't have to confirm by echo. You can start weaning based on the clinical assessment.
I think if the neonatologist is expert in hemodynamics echo,
Yeah.
I think I will repeat it.
Yes. Yeah, if you're able to repeat that and the person who is expert is available at the site, then for sure. Yeah.
Hi, so we have a term baby here, so she's 12 hours of age now. We have her on the jet and on nitric, but I am concerned about her blood pressure.
So let me, I have to show, I can give you a history. So this is still an infant born by normal vaginal delivery and clinically known case of congenital hepatic hernia on high frequency G ventilation, developed shock shortly after birth. Okay, so that's the case scenario.
Hi, so we have a term baby here, so she's 12 hours of age now. We have her on the jet and on nitric, but I am concerned about her blood pressure. Well, if you look at an hour ago, we had our initial blood pressure for a term baby was 50/31 with a mean of 38. And then just now, we're down to 40/23 with a mean of 29, which is quite low for a term baby for both the systolic.
Using the clinical.
Sorry. So I think you recognize the importance of the trend. So we teach our nurses to look at the trend of the blood pressure, trend over time. If you have significant drop over 1 hour, and even lactic acidosis, that's very significant issue that you don't have to wait until the infant dies from shock. So if you have the trend is down below the acceptable level for the gestational age, then we need to react. And we have the table. She's holding the table and correlating the numbers according to the table, the simplified table for the blood pressure. So we like blood pressure equal to gestational age, that's history. And that's not very evidence-based, and a lot of units like start continued even our unit until maybe 10 years ago. So let us.
Pressure for a term baby was 50/31 with a mean of 38. And then just now we're down to 40/23 with a mean of 29, which is quite low for a term baby for both the systolic, diastolic, and the mean.
Did he start to pass urine?
Has had no urine output since birth.
So partners and I surgery quite well. The baby's easily ventilated with injected ventilators on people at 8 and PIT at 32, giving us only 30% oxygen plus 20 parts of nitric oxide. The most recent blood gas has a pH of 7.27, CO2 of 56, flight carb of 17.5, with the lactate of 3.7 improved. And the oxygen histogram, starting with the highest and then the lowest overnight, is 7, 13, 70, 7, and 3.
Do you want us to call the hemodynamics team for a team echo?
And it's, you're right, the systolic and diastolic pressures on the low side. The pulse pressure is normal, which means there's a normal heart performance. I would consider giving vasopressor, either norepinephrine or vasopressin. But in the context of clinical pulmonary hypertension, or in started ILO, I would consider vasopressin.
Okay, so vasopressin was.
Now using the clinical decision support system to help in decision making of this case of heart. Remind you.
I have like case scenarios, but maybe if we have time tomorrow we can do it. But like that's an example.
First, about the most common causes of VAP. Now using the clinical decision support system to help in decision making of this case of cardiovascular shock. Our case was term infant, and systolic blood pressure was 40 at the time of assessment. Diastolic of 23, and mean blood pressure of 29. There was lactic acidosis greater than 3 millimole per liter, and also there was no urine output since birth. So, let us click on Calculate to get the physiologic impression. Okay, there was vasodilator shock due to low systemic vascular resistance. Notice in this category of physiology, pulse pressure was normal in spite of low both systolic and diastolic pressures. But let us assess the trend over time. So in the next page, the calculator will assess the difference in blood pressure compared to an hour ago. In this page, you need to enter the blood pressure values 1 hour ago or the previous blood pressure when the infant was considered more stable. Systolic was 50, diastolic of 31, and mean blood pressure of 38, and click to calculate. The CDSS calculates the difference between the two time points, and if it is more than 20% drop of blood pressure, this will be considered as clinically significant low blood pressure. And also, in the presence of either lactic acidosis or oliguria, the CDSS considers that as clinically significant shock. The next page is the assessment of the cerebral tissue oxygen by near-infrared spectroscopy. In this page, you need to enter the hemoglobin level as gram per milliliter. Arterial oxygen saturation, which was 95%. And cerebral tissue oxygen, which was 90%. The calculated fractional oxygen extraction was 0.05. It is low as the normal value is between 0.15 to 0.3. It is reminds you, first about the most common causes of vasodilator shock. As you can see, the system also helps to formulate a physiologic-based medical recommendation based on the blood pressure trends and previously entered clinical details.
So how is she doing?
So she's doing really well. So we've now been on vasopressin for 3 hours at 0.3 microunits per kilo per minute. And as you can see on our graph here, she's now well within normal ranges for a term baby at 58/41 with a mean of 47, which is right along here. So that's looking really good.
Did she start the fast fooding?
Yes, she is voiding.
And how soon?
It's, this latest gas is very good. So they're now on 28, we used to be on 32. And same peak, as we bleed the FL2 down the road, stats have been greater than 95. The most recent blood gas page is 7.29, and CO2 is about 51, and bicarb about 20. The neat thing now is that the lactic acid is improving still, it's up to up to 2.2. And what would you like me to do for nitric oxide? Is it time to wean?
Since blood pressure is normal now and baby started and we're on low air, I think it's a good idea to start taking the nitric oxide.
You have a selection option in this page to help in the weaning strategy. So, click here if you consider weaning after you selected the physiologic-based cardiovascular support. You should anticipate the response after the infused medication reaches patient's circulation, plus the known half-life of the medication. Half-life of the dopamine, dobutamine, epinephrine, or norepinephrine is about 5 minutes. Half-life of vasopressin, which was used in our case, is about 40 minutes. Half-life of milrinone infusion is about 3 to 4 hours if was given without a bolus dose. And half-life of the hydrocortisone is 8 to 12 hours. All of these half-life values might be affected by both liver and kidneys performance. So let us click to move to the next page. In this page, the system can check the readiness for weaning based on the blood pressure values. In our case scenario, the blood pressure improved after start of low dose of vasopressin. Systolic improved to 58. Diastolic to 41. And mean of 47. Then click to confirm the improvement. So all values are within the acceptable ranges. Then click Continue for the next recommendation. Here, as you can see, is the weaning strategy. Number 1, if all blood pressure components are acceptable. Then, wean gradually, every 1 to 2 hours, and recheck the calculator before each step to be sure that all components are staying acceptable or good. And wean by 1 unit vasoactive inotropic score until you reach the starting dose of the medication. 2, if most of blood pressure components are good or high, then wean faster, every 30 minutes, and recheck the calculator before each step. Wean by 2 units vasoactive inotropic score. If the infant is on multiple medications, then wean the category-specific medication at the end, for example, vasopressor in category 1 as the last medication. Wean steroid after weaning all other cardiovascular infusions, particularly if infant is confirmed with suprarenal dysfunction, which is relatively low, serum cortisol level, or steroid responsive.
Okay, so in this case, it's a simpler case. We did not do echocardiography. So we relied on the normal pulse pressure in presence of systolic, low systolic and diastolic, as we explained yesterday. This is consistent with vasodilator physiology. In vasodilator physiology, you expect the output performance is usually normal or even hyperdynamic, and that's usually we get when we do echocardiography. So in this case, we like the house stat just started vasopressin. Vasopressin is preferred because of vasopressin is a complication also for pulmonary hypertension. It might squeeze the venous return and might increase the venous return and either the pulmonary venous return or the systemic venous return. The blood pressure, as you can see in the continuous blood pressure monitoring, it's just 15 minutes after the start of low dose of vasopressin, and usually you start at 0.0003 unit per kg per minute, or if you are using micro unit, I'm not sure what unit you are using, it is 0.3 micro unit per kg per minute. And if you are using the right medication, you will see the improvement right away. We did not give any bolus for line in this case because that's a different scenario. Also notice in this case that we started to wean out oxide of medication, but it isn't just clinical. We did not consider echo, and we did not anticipate RV dysfunction because this infant really responded very well to the nitric oxide. This from air doing very well apart from the cardiovascular part. So that's much easier case to monitor. And we selected the medication that is fit for the underlying pathophysiologic enhancements, vasodilator physiology. We did not use dopamine, and we don't recommend to use dopamine in this case. Dopamine, it might work as a vasopressor, but you need higher dose, and you may get a lot of side effects. It might worsen the pulmonary vascular resistance, increase the cardiac oxygen consumption. In a case of probably HIV-related depression, that probably is dangerous. Increase brain oxygen consumption for premature babies. So a lot of side effects. So probably a lot of areas all over the world we started to revise guidelines to reduce use of dopamine. And even if you are obligated, you don't have other option, don't exceed 10 mics per kg per minute. Higher doses really, you'll get more side effects.
You know, in the UK, like many units are not using vasopressin. Actually, the majority of them, it's not allowed like to be used.
Yeah.
So it's more epinephrine in that case.
Yeah, norepinephrine might be alternative. So even telepressin is nothing because there is more. Yeah, in Middle East.
You know, remove the difficulty.
Yeah. So norepinephrine might be alternative. Norepinephrine is proven to be good for pulmonary hypertension. It is typically vasopressor, less impact on heart rate. So it is almost working the same way like vasopressin. So if you don't have it, norepinephrine would be would fit in this case. Yeah, any other question? So probably you are saturated now. Yeah, so maybe I think we are now running out of time, right? So Safar, we are done. We don't have questions. We are fully saturated.
Okay, the car is waiting for you downstairs.
Oh.
The car for the airport.
Oh, okay.
Yeah. If you have it.
Yeah, that's fine.
You need to.
Oh, yeah, my luggage.
Here. Allah.